because today is playoff day. The Knicks going for them. This ain't nothing, bro.
That can run the scout offense.
Look at the superstars. This is so exciting. The superstars. Look at you all. Oh, Trace, you look so beautiful.
Massages, facials.
And first and foremost, I would like to thank the Policy Saves Office and all of their staff for helping us bring this event to life and give us a beautiful safe space, as we all know how important it is to be in a safe space when we're having conversations like this. Thank you so much, Marissa, for bringing this all together with us, Dr. Ballot, and especially our guests, Dr. Men, Dr. Teplinsky, and Gila. It is such an honor to be here in this room, surrounded by so many powerful women. I'm Tracy, like I said, the founder of BRCAstrong. 10 years ago, BRCAstrong was founded by my daughter. It is based on my own personal story. I am a provider myself. 20 years ago, I found out I carried the BRCA2 genetic mutation when there was no community. Rooms were not full of women to support women, and I was living in a box by myself, not knowing what to do or where life was going to lead me. I just knew that I had an 87% chance for breast cancer, and that's why I stand here today in such an important room with experts to make sure that nobody faces what I faced alone in this community. We're going to go ahead and introduce each panelist, but before we do that, I'm going to pass it over to Nancy Antoine, who came all the way from Florida to help me MC this event, a survivor herself.
I focus on complex menopause management, breast cancer survivorship, another cancer survivorship, as well as BRCA survivors, and I'm a medical advisor at menopauseandcancer.org, which is a great resource for you all, as well as the Young Survival Coalition, and I'm a long-term 25-year breast cancer survivor and BRCA2 carrier and survivor of premature menopause. So my professional and personal really intersect in my mission.
Hi everyone, I'm Dr. Teplinsky. I'm a board-certified medical oncologist, and I specialize in treating breast and gynecologic cancer. And I practice at Valley Health System, which is in northern New Jersey. It's a Mount Sinai affiliate, and I see. Thank you.
Is this better?
So we don't talk about in the clinic, including menopause. Reorder.
Hi, I'm Dr. Anjali Malik. I'm a board-certified fellowship trained breast imaging radiologist, so I detect and diagnose breast cancer. And I'm also a board member of BRCAstrong. So I'm excited to be part of this conversation today, to be meeting two of my besties from social media, which is really how so many of us are connected. So I got connected to Tracy, and I'm sure it's how a lot of you heard about this event tonight. So, you know, due to the power of social media and us moving forward and taking care of our health.
Hi everybody, I'm Marissa Fayer. I'm the CEO of HERHealthEQ, and we are a global nonprofit focused on women's health in developing countries. So we provide medical equipment to lower middle income.
Some of you here, you may be experiencing a more abrupt medically induced or surgical menopause, but for those of you who are experiencing natural menopause, it doesn't always kick off with the hot flash and the night sweat. It can, and those can come and go. But I would say the most common symptoms are new onset of anxiety. Some of these things lead women to, when they present to their doctors, you know, kind of get dismissed because maybe their periods haven't changed much yet, right? Maybe they haven't had a lot of bleeding issues, and so when they present with insomnia, anxiety, or mood changes.
Different for individuals who've undergone surgical menopause due to genetic mutations or cancer treatments. In other words, what should they expect physically or emotionally?
So this is really important. Surgical menopause is not natural menopause. Premature menopause that is induced abruptly, either from a medication to stop your ovaries from functioning, and we do that for certain breast cancer treatment, or to lower your risk of ovarian cancer, or women might have surgical menopause for what we call benign reasons, ovarian cysts, endometriosis, etc. Doesn't matter what the reason is, it's abrupt. I like to call it a crash menopause. And even a postmenopausal ovary will still.
This is a big conversation kind of online, in the media this days, and feel free to chime in. But I think that for years, historically, people were told if you have a family history of breast cancer, if you had a genetic mutation, you could not have hormones, and I think we're going to get into that. But the question specifically about how does menopause influence breast cancer risk, we know that when we think about what are our breast cancer risk factors, we know that starting getting your periods early actually can increase breast cancer risk, and that may be one of the reasons we're seeing higher breast cancer risk now, because girls are getting their periods earlier than before. And there is some data that going through menopause later in life can increase breast cancer risk. But one thing I want to stress, and I think we'll all agree to this, is that estrogen does not cause breast cancer. I think this is really important. Estrogen can, if you have a diagnosis of a hormone receptor positive breast cancer, estrogen can fuel that growth, but the estrogen that you have doesn't cause breast cancer. So I think that's a really important point that sometimes gets lost in the conversations.
If I could chime in for just a second also, and you've probably seen it on my slide by now, but of note, even though we hear about the younger and younger ages of diagnosis of breast cancer and increase in the actual incidence in those under the age of 40, postmenopausal breast cancer is still by and far the most common age of diagnosis. If you see it there, it said that ages 62 to 65 are still the average age. So we're having all this talk about, estrogen exposure being the risk for the development of breast cancer, but we are still getting it as we age, because aging is one of the top two, or age is one of the top two risk factors for the development of breast cancer. So still very prevalent in the postmenopausal state.
And I do want to just add that, and I think it's very easy, and I did it myself for years, to say that because periods starting early and menopause late, so theory, of course, it seems like a longer time of estrogen exposure, and that's the reason why we see increased risk. But I think we have to be a little bit more nuanced and complex to understand that what happens to your breast tissue every single month when you ovulate. There's duct and glandular changes, there's microcellular changes, there's growth and division of cells. And when you are pregnant, when you're breastfeeding, there are other changes, hence why long periods of breastfeeding is protective. Being pregnant can be protective. And so we have to think that the cause of breast cancer, or why breast cancer develops, is a lot more complex than estrogen is exposed to or not. I think that's like an oversimplification that makes people fear their own hormones, and so, and I think that's part of the messaging that's caused a lot of fears with HRT. So I just think that's important to keep in mind.
Thank you. Dr. Mallory.
Yes, we all offline about this, but yeah, so in case you didn't hear that in the news, the American College of Physicians very erroneously put out some very archaic guidelines suggesting that mammograms not be initiated until the age of 50 and that they be done every other year. And there's so much data to support that and to prove that annual mammography starting at the age of 40 for those of average risk decreases mortality by 40%. And what's more, just to shoot a couple of statistics at you, 1 in 6 breast cancers is in an individual aged 40 to 49. 30% of breast cancers are in individuals below the age of 50, sorry. And so again, we know that there's an increased incidence in breast cancer in younger and younger women. Those guidelines just don't even make any sense. And they came at the same time as the NCCN guidelines. And people who were here last night will know the National Coalition of Cancer Networks. I get NCCN wrong. Oh, sorry. Oh, right, see? I got it wrong again. Anyway, the NCCN, I get it wrong every other time, came out with guidelines not only supporting the annually reporting, but actually promoting the use of a new AI. At the age of 35, when you have a baseline mammogram, this new AI actually predicts your 5-year risk for the development of breast cancer. So it was really terrible all around for the ACP, and they got the backlash that they deserved.
And just so you know, ACP doesn't mean they're the College of All Physicians. It's the Medical Society for the Board Certified Internal Medicine Doctors. And
What was that experience like physically and emotionally in those early years? And what do you wish you had known or been told about menopause in your options at that time?
So I'm 43. 11 years ago, I just knew that I was going into surgical menopause. I didn't know about heart health. I didn't know about bone health. I really was not given a full outlook of what I was going to be facing. Mind you, the most important thing that I think was missed was her mental health. I feel for 10 years that I struggled in every aspect and didn't realize how bad I was drowning. And I'm gonna kind of go back to Dr. Men. I was struggling for 10 years and kept asking for HRTs. Now, mind you, I am a 2-time skin cancer survivor. I did have major brain surgery 3 years ago, so I have had the works and reconstruction issues. But when I met Dr. Men, I was telling my story. And I'm not joking, you guys, Dr. Men jumped out of her chair. And I thought, like, if she could have told the doctor that told me no, or the doctors, it would have happened. I never knew the mental component of it and understood how like brain fog is real, weight loss was a struggle.
there's the osteoporosis that you told me about. Maybe
I had -4 osteoporosis throughout my entire body. I lift, I go to the gym, I'm active, I live a pretty good healthy lifestyle, but really just the mental component was the biggest part. As a single mom running an organization, helping everybody, I was not helping myself. Come to find out that I am a candidate for HRTs. I have started actually a year ago last year, and I've really, hands down, not because she's sitting next to me, my life has drastically changed. My friends around me look at me and they're like, who is this person? I can actually have patience, I can think, I feel good, and most important, body image has changed for me drastically. As I was going through menopause and having hot flashes, or going out and dating, I was struggling so hard to just know on the other side that there is light at the end of the tunnel. And with my history of not having breast cancer, I was able to go on HRTs, which have really been a huge game changer in my life.
I just want to add that it's important because you're going to hear us say 2 things at the same time. You can live well if you can't take HRT. That can be true, absolutely. But we also have to find the patients who can use it and remember that premature menopause, unless you actually have a true contraindication to hormone therapy, like you're going through an ER-positive breast cancer and you're under the age of 45, and we need to manage that differently. If we're removing your ovaries to prevent cancer, we've had guidelines, frankly, since since 2016, easily, even before then, showing that these women with abrupt surgical premature menopause, they really must be offered hormone therapy up until the age of natural menopause.
And standard of care, because there's a lot of companies that spend a lot of time and a lot of money lobbying for that as standard of care, when ultrasound or an MRI are just as effective, and sometimes more effective, especially in dense breast women. So that's where some of the MedTech ranges Q-tips to implantable cardiac devices, all regulated medical devices. So how is a cardiac machine or implantable, how is it different for women versus men? So we have to think about that. And we have to think about that, like, while we're here in New York, it's wonderful and lovely, we also have to think about how it's failing women everywhere around the world. And that's one of the most important things that, you know, yes, we do most of our innovation here in the US and in Europe, but we have to think about how this also applies to everyone around the world, because there are some significant changes when you're in, you know, New York City and you're going to any of our very fancy hospitals here versus going to a hospital in rural Kenya. That care and the devices have to be different.
To help as many women as we can. Multiple states, as an example, limit the number of magnets that can be in a certain area. Virginia is one, North Carolina is one, and I have work in both. And so my practice, I'm in the DC area. We can add magnets to DC and Maryland. We can't add them to Virginia. The hospital systems might be able to, because they have a little bit more clout, but like regardless. So mammography, X-ray of the breasts, it is the population-based standard for screening. It detects calcifications. It's the only modality that can detect calcifications, which is the earliest sign of breast cancer. It is cheap, quick, easily accessed in relation to many other things such as MRI, which I already referenced can be difficult to access. Reimbursed. And yes, it's reimbursed, and it yes, versus MRI. And it has good detection, sensitivity, and specificity. Whereas some of the other modalities might be harder to access, etc. Because of unfounded fears of radiation. So the radiation from mammograms is safe. It is within FDA limits, and if you take a flight to Paris or a flight to Seattle, you're getting as much radiation as you would during a mammogram. But because of those unfounded fears, many decided to exploit those fears and come up with the concept of thermography, which is, I think, looking at areas of increased heat, with the theory being its increased activity and that theory being that it's cancer. So that's false. Thermography is not FDA approved. There's no evidence to show that it detects breast cancer or any cancer. And if you want something that does detect cancer better than mammogram, it's MRI, doubles the level of breast cancer detection. Actually, any kind of test where you are getting an IV, I met my coldest. I just waved my hands around enough. So anything where you get an IV and something is injected through that IV is taken up in areas of increased activity and doubles the level of breast cancer detection. So that's a contrast mammogram. You might hear about molecular imaging or the MRI. So thermography is a no-go, which again, I think a lot of you already knew in this room. Mammography is the standard. Nothing replaces mammograms at this time. So even if you are getting an MRI for high-risk screening or dense breast screening, the only way we're going to find calcifications, the earliest form of breast cancer, is via mammogram regardless. So mammography, X-ray of the breasts, it is the population-based standard for screening. It detects calcifications. It's the only modality that can detect calcifications, which is the earliest sign of breast cancer. It is cheap, quick, easily accessed in relation to many other things such as MRI, which I already referenced can be difficult to access. Reimbursed. And yes, it's reimbursed, and it yes, versus MRI. And it has good detection, sensitivity, and specificity. Whereas some of the other modalities might be harder to access, etc. Because of unfounded fears of radiation. So the radiation from mammograms is safe. It is within FDA limits, and if you take a flight to Paris or a flight to Seattle, you're getting as much radiation as you would during a mammogram. But because of those unfounded fears, many decided to exploit those fears and come up with the concept of thermography, which is, I think, looking at areas of increased heat, with the theory being its increased activity and that theory being that it's cancer. So that's false. Thermography is not FDA approved. There's no evidence to show that it detects breast cancer or any cancer. And if you want something that does detect cancer better than mammogram, it's MRI, doubles the level of breast cancer detection. Actually, any kind of test where you are getting an IV, I met my cold just now. Just waving my hands around that. So anything where you get an IV and something is injected through that IV is taken up in areas of increased activity and doubles the level of breast cancer detection. So that's a contrast mammogram. You might hear about molecular imaging or the MRI. So mammography is a no-go, which again, I think a lot of you already knew in this room. Mammography is the standard. Nothing replaces mammograms at this time. So even if you are getting an MRI for high-risk screening or dense breast screening, the only way we're going to find calcifications that really is form of breast cancer is via mammogram.
Take it. And the bone loss, which has been a constant battle of bone strengthening supplements and DEXA scans and figuring out, you know, where to get the most benefit. But no, these things were definitely not, I was not made aware of these things and I had to figure them out for myself.
So I have a quick question.
Sure.
So just with Dr. Teplinsky, Dr. Ben here, I know we have a lot of AYAs in the room. At what point, if you see somebody like for prevention or for survivorship, do you talk about menopause? Like, why do I feel like when I talk to women, it's like the last thing that they're learning about, like especially women that are starting treatment and are getting hormones and treatment. At what point do we as a community, with like so many advocates in the room, like what advice can you give us to help the community so we don't suffer?
I think there's a couple of points to it, right? So we have to think about what's happening. I'm gonna speak from a medical oncology perspective and from a GYN perspective, but from a medical oncology perspective, when we meet someone, right, there is so much to cover. I mean, there is a lot. And there's a really fine balance, and I struggle with this every day, about how much do you share, because I am sharing so much information. When I just start talking about chemotherapy side effects, 10 minutes and people are like, can I go? I want to go now. Like, I'm done. Like, because I'm going, it's your hair, let's do scalp pulling. Okay, we're going to appetite, blood counts, joint pain, and neuropathy. We're going to do this. And right, so there's so much. We're going to monitor your organs. And so it's overwhelming. And so we have to draw a fine line about, like, I don't want to scare people. I want to prepare them, but there's a lot to cover. And I think that we have to keep in mind that menopause is not taught in medical oncology education. It is not taught. I had not a single lecture on it, and my mentor is an incredible oncologist. She didn't know, so I didn't know. And we're starting to think about changing that. There's a big push from menopause education in oncology. But menopause, and right, if you think about, well, why did my oncologist prepare me? Well, they weren't taught about it. There's not enough time, I hate to say it, but it's true. And only for the first time, I would say in the last year, we're starting to see menopause be on the stage at oncology conferences. Before, it was relegated, not relegated, but it lives, and it still lives in the GYN space.
They barely lived there
Yeah.
until recently.
And so your oncologist isn't going to the GYN conference. They're going to the oncology conference. And if it's not on the stage at the oncology conference, where are they learning about it? So it's a system error. I don't think it's anyone's fault. I think we're starting to change the dialogue, but it really is a fine line of, I want to prepare my patients, but I don't want to scare them, because we do have to get these treatments, and these are life-saving treatments, and so it's a balance. And I think that the conversations are changing, but we have a long way to go.
I mean, obviously, I'm seeing patients who are seeking me out for menopause, so of course that's all I'm speaking about. But the advice that I give to newly diagnosed patients who maybe are not my patient, or even they speak at a conference, or advice that I give to busy doctors who are trying to do the best, I say, and I really will take this question from a patient perspective, because I was that patient 25 years ago. Nobody prepared me, and I was a second-year OB/GYN resident. We think I would have known, but we had no menopause education, and so they were very concerned about ovarian function, because they really valued my ability to have a baby, because I valued that. And it's a long culture and history in the oncology world that we do talk about fertility preservation. Because I also think this goes beyond any one person, and it's society values us for our baby-making capabilities, and once our reproductive capacity ends, well, okay, like that doesn't matter. So they rushed me in to preserve my ovarian function, you know, protect and preserve eggs. But when I was dealing with onset of panic attacks, hot flashes, insomnia, The only thing I got was a prescription for Xanax, which is actually not the appropriate medication for sleep disorders. And so, what I would just say is if you've got a friend out there or someone who is dealing with a brand new diagnosis, sometimes just one or two simple sentences. You're gonna have to take care of a lot of information. Here's a couple of good resources. Menopause and Cancer has become my favorite because it's a nonprofit and there's a lot of great resources. And just know that there are so many, you should not suffer. We have a toolkit and we're gonna get it to you and we're not gonna make you wait. And let's focus, again, you gotta deal with the treatment and the surgery and that, but upfront, even just a little message, I'm not gonna forget about this, and we need more menopause specialists to refer patients to. But this is where you and your friends and your networks, you have to empower them. Because well-meaning, we're all good, well-meaning, all the doctors are well-meaning, we all come into medicine to take care of patients because we care. Time and the institutions are not necessarily supporting what
1 in 10 women are leaving the workforce very specifically just because of menopause symptoms, and they cannot handle it. It is actually getting worse. It's now trending towards 1 in 8 and 1 in 7. Like, there are physically hundreds of thousands of women leaving the workforce because the symptoms are so bad and they're not getting treatments for it. So I can't even imagine when you're also going through medically induced menopause and had to deal with breast cancer and all of these other things. So corporate America just needs to step up and actually have the flexibility, access, and just, I don't know, like a little bit of compassion for women who need to step out and like are sweating.
So over the past decade, I have suffered in several ways that I never want somebody else to suffer in, and I take that and really just turned it into my guiding light of saying, if I struggled for 10 years and I had severe osteoporosis and I wasn't sleeping and I had low sex drive and I didn't want to date, I don't want anybody else to ever have to walk that path. So that is why I do what I do on a daily basis and come from different states to bring panels like this together, because with that one story that one of us each shared, we hope that we touched each of your lives and that you can go out and share with your family and friends so they don't suffer.
Thank you, friend. I do see what you do on a daily basis. This woman, she's a rock star. Now this question first. Who's an ideal, how can previvors and high-risk women advocate for themselves if they feel dismissed or told they are too young to be in menopause?
I'm kicking that off.
Let's go.
I think we have the light of technology right now, and we need to take that to our fullest advantage. Yes, we all have insurance, and unfortunately, our insurance doesn't allow us to see specialists, including menopause specialists. And I think going on and knowing that you can also have virtual options, and just because your doctor's like, no, well, maybe seeking a second opinion is the most imperative part, and really listening to your gut. Because again, nobody should suffer after going through what I went through and now turning on the other side and feeling the way I feel.
Yeah.
Great advice.
I think high-risk women and previvors know that menopause can be managed, and if you are feeling dismissed by your doctor, the best advice I have is make an appointment specifically for what you're looking for, write them a message saying this is what I want to discuss at this visit so they have a heads up. And just let them know if you don't feel comfortable with managing menopause for me as a high-risk patient, can you refer me to a colleague? And so be a squeaky wheel.
I also just wanted to add one thing is, again, I want everyone to talk about it so that when people also see it online or when you're speaking to friends in other locations, maybe it's in this country or outside of this country, you have to understand that we're valued to have these conversations here, but they're not necessarily going everywhere else. And so think about this on a global scale on how we can have those conversations, how you can spread this information, how you can spread everything that we talk about to everybody else who doesn't have access to this.
Yeah, and I'll add to that. We are living in a moment where menopause is everywhere. Everyone's talking about it. There's all the influencers, and I think that regular people like us can take advantage of that momentum by really speaking up for ourselves. And if you don't like the answer that you're getting, there's no shortage of medical professionals and organizations that will give you what you want and or